Okay, we're going to go with Unit 3. This is the hyperthermia and hypothermia lecture. I'm going to keep my screen with this view because then you guys can see my notes. All right, so kind of a brief anatomy and physiology review of the thyroid. So we talked about the thyroid a little bit last semester, but kind of just going over it again. So the pituitary gland, which is found in the brain, is what releases a hormone to tell your thyroid how much to kick up. Okay, and your thyroid's job is to turn the metabolism on and off in the body. Okay, essentially is what it's doing. And so the pituitary gland is going to monitor that and regulate that. So how does it do it? Well, through hormones. Remember, we talked about with hormones, it's a form of communication through the body. So the pituitary gland releases TSH, which is the thyroid stimulating hormone. This is a very important hormone. This is one that we can easily measure with a lab test. And so then that TSH makes its way through circulation to the thyroid gland. And then the thyroid gland produces three main hormones. They're going to be T3, T4, and calcitonin. The one that we look at most often is going to be this T4. We also call it a free T4 when we're looking at it in a lab test. Okay, so we're going to start off with hyperthyroidism. So hyper meaning, too much, excessive. So with hyperthyroidism, the thyroid gland overproduces the thyroid hormone. So the thyroid hormone, we're focusing on the T4. Okay, essentially that's what we're looking at. This is the most common endocrine disorder, and it's commonly found in women and older adults. There's a kind of a picture here that shows what we expect to see: some bulging eyes, possibly a goiter with that enlarged thyroid gland. So common causes, this can be an autoimmune response, that the thyroid is just going too much. Excessive doses of thyroid medication. So if this is a person that's been hypothyroid before and so they're taking like an additional thyroid medication, well, maybe now it's too much on the body for whatever reason. And so they're starting to get this hyperthyroidism. Or an excess secretion of TSH. So maybe the pituitary gland is malfunctioning. It's not getting the right signal. So it thinks that the thyroid needs to kick it up more. So we think about the different labs that we'll see with this. So, if it's a case where the pituitary gland is overreacting, then we expect to see a high TSH level, right? And then if we're looking at what the thyroid gland is doing, so if we have hyperthyroidism, then that T4 or free T4 level that we're measuring in the blood has to be high as well. So with this case, high TSH and high free T4. Here's another scenario for you. Say the pituitary gland is functioning just fine. What do you think the pituitary gland would be doing if the thyroid is overproducing? So the pituitary gland would want to tell the thyroid to slow down. So in that case, we're going to see low TSH, but a high free T4. Okay, that the brain, we can see that the brain is telling the thyroid, you got to slow it down. So what is the result with too much free T4 in the blood? Well, that's an increased metabolic rate. Signs and symptoms, we have quite a few of them here. Increased appetite, yet loses weight, nutritional deficiencies, cardiac dysrhythmias that can lead to heart failure, tremors, insomnia, diarrhea, shortness of air, tachycardia, hypertension, palpitations, amenorrhea, intolerance to heat is going to be, that's kind of one of those key things. These people just cannot tolerate any heat. They want to be in their air conditioning with hardly any layers of clothes on, it seems like. Excessive diaphoresis, and then the fine, thin hair is also one of those signs. So the weight loss, but with an increased appetite, and then fine, thin hair, intolerance to heat. Those are key assessment findings. All right. Graves' disease, this is the most common cause of hyperthyroidism. This is typically found in women that are under 40 years of age. One of the key assessments with this is going to be a goiter. So a goiter is this enlargement in the neck. Okay, this is not an Adam's apple. People get this confused with an Adam's apple. This is not that. This is the thyroid actually has enlarged so much around that trachea that we can see it bulging from the neck. One of the ways that we can assess the thyroid, and you can see it here in this picture, is the doctor or nurse stands directly behind the patient, and then we actually have the patient turn their head to the side, and then the doctor will pull their trachea just a little bit to that same side. So if we have them turn their head to the left, we're going to pull the trachea to the left and then feel in that right spot to see the right of the trachea to feel if we can feel that thyroid bulging. We should not be able to, but if we do, that's an abnormal finding. And then we'll have the patient look to their left. The doctor or nurse will pull the trachea slightly look to the right, trachea slightly to the right, and then palpate to the left of the trachea again. Another thing that we look for is exophthalmos. Sorry, guys. This is a forward protrusion of the eyeballs. You can see this in this picture here. The eyelids retract, the sclera above the irises, decrease. There's an unblinking characteristic stare to these people. They usually are affected bilaterally, where both eyes are affected, but sometimes it can just be one eye. Obviously, they can't blink very well or efficiently or effectively, so we have an increased risk of infection, dryness, and ulcerations of the eye. And ulcerations of the eye, you guys, are very, very, very painful. People that get them will tell you it is like one of the most painful things they've ever had happen to them. And this becomes a permanent condition. Treatment, we're going to get to that on another slide here. Here's a picture that I just wanted to pull up here. If anybody likes to have these for, extra studying, the weight loss with the safety pin, diarrhea, tremors, menstrual changes of, the amenorrhea, bulging eyes, facial flushing because they just feel hot. They're just, the metabolism is just cooking them, right? Fine straight hair, tachycardia, high systolic blood pressure, that kind of thing. All right, thyroid crisis, also known as a thyroid storm. This is an extreme high metabolic rate. It is rare and a life-threatening emergency. So I've got my little picture here. This is actually a thunderstorm over a volcano that is active. Isn't that kind of cool? Like, this is a real photo that was taken. Not mine. That would have been cool, but no, not mine. Anyway, I have seen a thyroid storm once, and this person was very sick, very lethargic, couldn't really communicate with us at all. And it was very scary once we got those labs back and knew what was going on. So you got to think about rapid rise in metabolic rate. So what are things you're going to expect happening? Something high fever, right? The metabolism is going very fast. So high fever over 102 degrees Fahrenheit. What goes along with that? Tachycardia, okay? Hypertension, just restlessness, that feeling that something is going wrong but can't explain it. Tremors that can progress into seizures. And I believe once this lady, we had to transport her elsewhere. She did have a seizure when she got there. A decline in LOC, which we definitely saw. She went from, being able to answer our questions to just very confused. And they can progress from confusion to delirium to coma. This requires hospitalization in the ICU and immediate reversal to preserve cardiac and other organ functions. They're going to get anti-thyroid medications, acetaminophen to try to bring down fever, and cooling blankets. We need to keep them cool. And, they're heating from the inside out. So it's really, really hard. We're going to be pushing, cold fluids. You might even see gastric lavage to try to get their temperatures down, where we put cold water into their stomach and then we can, pull that back out. Okay, moving to my next slide here. So hyperthyroidism, I already talked about the diagnostics. The main ones we're going to look at are going to be the labs TSH and free T4. We can do a free T3, and we can look for radioactive iodine uptake, meaning if we do some kind of a CT or an MRI with contrast, we're going to see this thyroid light up like a Christmas tree, because oftentimes that'll just mean like maybe there's a cancer or something going on, that's why this thyroid is overproducing. The treatments depend a lot on age and severity of the condition. Medications for antithyroid, we have a couple of them listed there. The methimazole and the propylithurazole. This may take several weeks to see any improvements because it does not destroy already produced free T4 and free T3. They can cause nausea, vomiting, fever, rash, itchiness, loss of taste, agralocytosis, which is a low white blood cell count, and then, any hypothyroid symptoms. So we can destroy, the thyroid function so much that now they're actually going to be hypothyroidism type symptoms. So why does this take so long to recover from? Well, if you remember back from last semester, I talked about that levothyroxine sodium, which is that hormone replacement therapy for hypothyroidism. It takes something like 6 weeks for it to build up in the system. It's the same thing with trying to eliminate the thyroid function as well. Radioactive therapy is very common. This destroys thyroid cells so that we produce less thyroid hormone, less of that free T4 and free T3. This is given orally, and the treatments usually last 6 to 8 weeks. It may require thyroid hormone replacement therapy once it is done. Elimination takes 2 to 3 weeks, and it's excreted through urine, saliva, and feces. Because of this type of treatment, there are usually no radiation safety precautions with this. Typically with radiation safety precautions, it's like, staying so many feet away from newborns, pregnant people, people with immunocompromised status, watching where you're going. You have to usually stay inside. That with this type of treatment, that is not usually the case. However, every doctor has its own recommendations as well. Surgical therapies. So we can do a subtotal and total thyroidectomy. So subtotal is going to be like part, and then the total is going to be the whole thing. So subtotal leaves just enough for proper production. This is an option for pregnant women because they can't have radiation, or people with impaired breathing due to a goiter. So if that goiter is so large that it's actually cutting off the trachea, they have to go in and surgically take it out. Total thyroidectomy is for people with cancer, with thyroid cancer. They will need lifelong thyroid hormone replacement therapy. This patients need to be in a euthyroid state, so a balanced state before surgery if possible. Complications. This is in a very vascular area right next to the airway. So we think about all those places there. Hemorrhage, respiratory distress, laryngeal nerve damage, which would be your voice box. Tetany as a result from some parathyroid damage that causes a hypocalcemic state. And then a thyroid storm where it actually goes the other way very drastically because of this trauma can happen as well. All right, hypothyroidism. So hypothyroidism, this is the thyroid gland produces insufficient amounts of the thyroid hormone. Etiology can be a congenital defect, antithyroid medication, surgical removal of the thyroid, iodine deficiency, amiodarone use, and lithium carbonate use. Assessment, so what do we see? What are these patients usually going through? This usually typically has a slow onset. It takes a while for us to get a good picture of what is going on. Remember, it takes like 6 weeks for the therapies to work. So it's gonna take that long to see these types of signs and symptoms and start making a pattern. Often we will see a goiter with this as well. Pleural effusion can happen where fluid is building up around the lining of the lung. Constipation, because things are slowing down. Remember, now we've got the metabolism is sluggish, right? So constipation, muscle stiffness, weakness, fatigue, those are 2 common signs and symptoms. Muscle cramps, lethargy, memory impairment, personality changes, become slow and clumsy with their movements, may have edema around their eyes, can have hypotension, bradycardia. We've got the opposite now, remember? Dysrhythmias, menorrhagia and infertility, decreased libido, hair loss. Hair loss is a key one. This is one that we'll see that they're like, well, now my hair just keeps falling out. Brittle nails, dry skin, non-pitting edema of hands and feet. Weight gain is another one of those. Can have anorexia just because they don't have energy to go get food as well. Intolerance to cold is another big symptom there. These people feel cold all the time. Their metabolism is not keeping their